call on our next presenter, Michael Lipton. He'll present the tools for the delineation of regional MR diffusion abnormalities in individual patients. And Michael is from Albert Einstein College of Medicine and Yeshiva University. You can either use that or this.
Hopefully this will work. Good morning. So I'd first just like to thank Mike and the sponsors for the invitation. And you know, I was thinking yesterday, I had the chance to, someone gave me a ride on the Autobahn, and it gave me a thought that in terms of the approach to imaging and the things that I'm going to talk about, when I saw all of this traffic flying by very quickly in one direction and I was moving in the other direction, that there's really this sort of binary idea that there's been quite a lot of work that has been done applying diffusion imaging and specifically diffusion tensor type imaging to traumatic brain injury. But I think that there's a lot to do, and what I'm going to try to do is make the case for really a bit of a transformation in the way that we look at these data, which I think could have a very significant impact on the yield that we could get from data that we're already collecting. So the goals that I have are first to take a look at what's in the literature, and then to make a case for what I'm going to refer to as patient-specific identification of diffusion MR abnormalities. Now, I use this term diffusion MR, DMRI advisedly because there are so many different permutations of diffusion acquisition methods and data analysis methods, and we need to keep an open mind to that variability and variety. So this is a paper that came out electronically at the beginning of the year that I had a few students working very hard for quite a while to pull this literature together and really comb through it very carefully. And what I put here was one quote from the paper, which is that the overwhelming consensus of the 100 studies which we reviewed, which looked at the application of diffusion tensor imaging to traumatic brain injury, and I'll give a bit more detail in just a minute, is that across all these studies, the finding of low anisotropy seems to be characteristic of traumatic brain injury. And specifically, we're talking about applications where patients are compared to controls. And the question that I want to raise, which we didn't raise so much in the paper, is that should that really be expected, right? Should we expect to see all of these studies, as different as they are, sort of converging to the same implication? Now, the graph on the right is from the paper, and it shows the exponential increase in studies applying diffusion tensor imaging to TBI. And I was thinking last night about why we have that little dip in 2009. I thought it might have been the financial crisis of 2008 catching up somehow. But we recovered faster than the economy in terms of the movement of this research. So this study looked through the end of 2011 at 100 papers. And since then, conservatively, there are at least another, more than a dozen papers in the literature. And it's a very varied literature. We look at subjects in these papers from the mild to severe end of the spectrum, from acute to chronic TBI. Technical details of the studies vary greatly, whether it's field strength, number of diffusion directions, other parameters. The data analyses vary from region of interest approaches to voxel-wise approaches, tractography, and the types of outcome measures, which by the way, are only evaluated in a subset of these studies. Many of them are simply comparing patients to controls. But when those outcome measures are assessed, they are quite variable in terms of the types of things that people are looking at, whether it's symptoms, whether it's cognitive outcomes or others. And when we looked at this, which would be the literature through 2011, there were relatively few longitudinal studies, and we have more now, but that's still clearly an underserved aspect of this field. So from all of those studies, and in spite of the tremendous amount of variation, again, I think the sort of take-home message that we can pull away from this is that low FA is a characteristic of patients with TBI when we compare them to controls. And that shows up across the board, regardless of severity, regardless of time from injury, regardless of technical factors of data acquisition, regardless of the data analysis approach. Now, another thing to think about is that all of these studies looked very differently at where in the brain the measurement is extracted from. And what we're seeing across most of these studies, and I'll get to this in the second part of my talk, is that we're always looking in virtually everything that is reviewed here in a comparison between a group of patients, which may be more or less variable in its composition, and a group of normative subjects, controls. And in delineating areas of abnormality in that type of a comparison, we're identifying areas that are commonly affected across the group of patients. So I think that the way to understand what that means is that we are detecting areas in the brain that are commonly affected across these subjects, perhaps may be more susceptible to TBI, but I think it's important to recognize that in no way can that mean that we're necessarily delineating the full scope of the spatial distribution of injury in the brains of the individuals in that patient sample, and I'll get back to this. Low FA is not only characteristic of patients, but it is also associated with the typical types of adverse outcomes in terms of symptoms and cognition that we're all concerned about. I think at the time that we put this paper together, and even with the expansion of the literature over the last year plus, the prognostic role of these diffusion measurements remains uncertain, right? There have been some recent interesting messages from some additional longitudinal studies, and I put one of them here at the bottom, looking at severely injured patients. But the effectiveness with which we can use diffusion measures to not just detect abnormalities in TBI patients, but to say something about what they're going to be looking like down the road, that remains sort of unclear. And I think that that brings us to the sort of missing pieces which many of the people in the room here and in the community can certainly address in trying to move the field forward. The first is there's clearly a need for more effective approaches to trying to classify subjects as to what they're going to be doing in the long run to be able to develop prognosis. And I really just raise a couple of questions here, which first is the types of longitudinal studies that we're seeing, which look again homogeneously across a group of clearly very different individual patients to try and identify predictors of long-term outcome. If we do more and more studies with more and more patients, are we likely to get traction on the ability to predict a prognosis in a specific individual patient? And in the same vein, diffusion imaging, imaging in general, is a tremendously complex and rapidly evolving field. The studies that I'm talking about here used a relatively simple approach, diffusion tensor imaging. And as we all know, there are increasingly complex ways to both acquire and analyze diffusion data. I'm not sure, though, that we've exhausted the benefits of the existing more simple methods, and it might have to do with the approach to imaging. And then secondly is that we clearly need methods that can allow us to look at individuals to delineate abnormalities that can then be used in clinical care, hopefully in the context of evidence that shows that those measures are actually useful. So I put this picture up here. This, of course, doesn't happen on the Autobahn. This is probably in the States, or actually maybe in Israel it would be most common. So there's a head-on collision, and the two drivers are both in that seemingly same mechanism of injury. But for us to assume that even though there's a relatively similar mechanism affecting these two individuals, there are so many factors that will affect the distribution of pathology in the brain that is it really possible, is it reasonable to expect that an analysis approach where we go and we look in the same place in all the patients for the injury is going to be the most fruitful or the best approach. Now, I'm a radiologist by background, and I teach radiology residents, and we teach all of our residents and students that there are certain areas in the brain that are just hallmarks, right? They're typical locations for TBI pathology, and that's certainly true. But that's a different statement from looking at an individual person and trying to understand the totality of their injury and how it's going to affect their outcome, which really requires an understanding of the more complete picture. So in looking at the way we all, myself included, have been applying diffusion measurements, may be done in a somewhat unreasonable manner. And if I'm being a little provocative, forgive me, but I think that there's really room for a change here. And in this paper, we actually argued for many, many reasons, ranging from genetic predisposition to biomechanics to anthropometrics to many factors, that there is such a huge amount of variability in the patients and the mechanisms of injury that is it really reasonable to expect that those injuries are going to look very similar amongst individuals. And in terms of the approaches that we all take to trying to generate usable data, we're using very commonly, if we look across these studies, at a priori regions of interest, where we just decide that the corpus callosum or the SLF or some other specific region is the place where the injury is going to happen. And we define relatively large regions of interest, right, whether those are simply drawn on the image or extracted from some canonical atlas or tractographically described. And this doesn't really account for inter-individual variation between these subjects, which is potentially, at least, really an area of opportunity. So to make this case, and in a very limited amount of time, I just want to lay out a little bit of my own experience in trying to define ways that we can define in individual patients where their brain abnormalities, or at least some of their brain abnormalities, lie. So first off, in terms of why we need to do this, is clearly for ultimate clinical application of a technique like this, we need to be able to define an abnormality in an individual. And I think that arguably, as I've been discussing, that this is really a potential fruitful avenue for future research in TBI and perhaps to better define outcomes. I want to be clear, though, that when I talk about individualizing the assessment, what's individualized is the delineation of the abnormality. So the predictor variable, for example, that we extract from the diffusion data to model outcomes is something that is defined on an individual subject basis. And I've encountered some confusion here because clearly the ultimate analysis of these data sets in determining outcome is done at the group level, but my question is related to the predictors that go into that. And there are a variety of studies that have looked at these approaches. I think another thing to realize is that in the literature of these group-wise measures, that many are using data extraction methods, delineation of abnormalities, that are in fact individualized. The measurement comes from an individual patient specification, but those are often defined the same way across individuals. And lastly, while this is of course not a really reliable form of evidence, there's a large and expanding literature of case reports. So in order to do this, in order to take a diffusion MRI data set in an individual patient and make an inference that there is an abnormality in that diffusion parameter at a specific location, what do we need? So ultimately, this involves taking data from a patient and data from some normative body of data and defining that there is a difference. And there are various technical hurdles to be overcome, the stability of the MRI measure, the comparableness, so to speak, of that normative data set. And this is a major issue, especially for large multi-center trials. Co-registration, are we really comparing the same location between the patient and the controls? The way we quantify the presence of the abnormality, and what are the thresholds for abnormality? One thing I'll point out is in my last statement here that these are what I call ROI agnostic approaches, meaning the way that you define the region of interest, whether it's a tract, whether it is a specific hand-drawn region that you're interested in, whether it's a whole brain approach like a voxel-wise analysis, you still need all of those other steps in order to make these assessments. And an approach that we've taken in my lab and actually have applied in the clinic as well is using a modification of a voxel-wise z-score approach. So there are really two issues here, and I don't have the time to go into much of the technical details, but the first level is simply identifying areas that are potentially abnormal, and the second is what's the approach to really thresholding and defining where those abnormalities are. So what we do in a nutshell is to, first of all, adjust the data for demographic covariates that we suspect will be significantly impacting the diffusion measurement, things like age, gender, education, could be anything. We compute a voxel-wise z-score that has been optimized by resampling the variance. And the key reason here is that we're looking at a relatively small reference group, which we're not sure how representative that group may be of the larger population against which we want to make the inference. And we've done a tremendous amount of modeling and validation looking at various compositions of reference groups to try and define this. And then those images get thresholded. Now, this is just an example from 3 individual patients where the areas in red are areas where the FA in the patient is significantly lower than it is in the control group, and the areas in blue are areas where the FA is significantly higher. And one thing to point out is that across these patients, we see that there are multiple areas in each individual. And I should point out that in these cases, these are all patients with normal structural imaging, right? No hemorrhage, nothing visible on the MR. And there's clearly a variability in the spatial distribution. This is the way we present this data in the clinic in an individual patient, right? So the areas of abnormality are delineated in the images below. And this is giving us a sense of the range of the normal population and where the subject sits at these locations. So I like to think of this in dealing with clinicians as presenting them with data. If we think about how could this be presented in a usable way, when a clinician orders a serum test like glucose, they get a measurement and a normal range. So providing a map of where we've detected abnormalities and how that stacks up against what we can expect in the normative population is potentially at least a clinically useful piece of information. So in terms of the what I like to call the sort of technical overhead to doing this in individual patients, there are many factors to consider. And the movie on the right is just one, where what you're looking at is the diffusion data set the EPI data set before and after we correct for magnetic field inhomogeneity. And you'll see as we scroll through this that the actual location of brain structure is significantly impacted by those distortions. If you're not correcting for this, then do you really know where your measurements are even coming from? And in terms of data quality, consistency, temporal stability, how you do these analyses, this is not a trivial pursuit, and there's a significant amount of room for developing approaches, especially if you look at this one, to dealing with these problems in a turnkey way that can be rolled out to multiple centers. You could imagine in a multi-center trial, if this effect is being accounted differently at different locations, we don't even know that the same part of the brain is being tested across those locations. So I think in light of this, where I really want to end up is that I think that diffusion MRI, simple, the diffusion people call it basic DTI, right? DTI, which is, you know, we couldn't have imagined it when I was a resident, and now it's considered sort of, you know, passé in the era of diffusion spectrum imaging and other techniques which have had tremendous power. But using simple DTI and thinking about the fact that most of the studies, particularly the studies that look at diffusion measures as predictors of outcome, are based on group-level identification of abnormalities. And it's unlikely that the injury mechanisms, that the substrate that the patient brings to that injury is uniform across patients. And if this variability is present, right, and I put this quote in from another review, is it really likely that we're maximizing the power of the technique if we don't account for this amount of variation? And I just want to lastly quickly show you a little bit of data from my group looking at classification of outcomes. So we took a group of 26 mild TBI patients, and what we're looking at here is imaging within 2 weeks of injury and post-concussion syndrome diagnosis based on ICD-10 criteria at a year following the injury. And what we see is that when we use a simple voxel-wise t-test comparing the group of patients to the controls to identify the areas of potential abnormality, that the bottom line is that we did not find any significant association either in a correlation or in a discriminant function analysis to classify patients based on those regions of interest. Right, the correct classification is about 73%. But when we use the individualized analysis, meaning we identify areas of abnormality in each individual, and we average the diffusion parameter across the abnormal areas in that person, and that becomes the predictor in the group modeling analysis, we find that there's a highly significant association of initial radial diffusivity with worse outcome, and that it's highly effective in discriminating and defining that outcome. So I think that by going this route, right, using these sort of what I cautiously call data-driven approaches to delineating these abnormalities, acknowledging the problems in being able to do this have significant clinical and research implications. First, this is a technique that is designed and is able to identify abnormalities in individuals. So the potential for clinical translation is there. And I think what I'm showing is that there's also significant opportunity for improving prognostication. In research, I think that there's a huge amount of important information on interindividual differences that we're not accounting for. And lastly, I just want to acknowledge the large group of people and funders who make this possible. And lastly, being in Germany, just point out that we're all trying to get to a certain point. But in my training, I was told that always taught that the enemy of good is better. And we need to be realistic about trying to make some significant incremental progress without losing sight of that. So thank you very much.